Welcome, folks, and we appreciate you taking the time to join GRM for a panel discussion of just how the current pandemic has exposed the weaknesses or cracks in certain aspects of both the clinical and business operations of healthcare. Joining me for today's discussion is Dr. Tony Napolitano, Chair of the Department of Pediatric Medicine for Johns Hopkins All Children's Hospital, Cheryl McKinnon, Principal Analyst of Enterprise Architecture for Forrester Research, Jeff Becker, Senior Analyst of Healthcare Channel Strategy for Forrester Research, and Doug Turner, Consultant and former Chief Information Officer of HCA Physician Services. Welcome, ladies and gentlemen. Industry pundits often speak of disruptors in their areas of expertise, and while these disruptors are generally new software technologies, we contend that we are in the midst of the largest disruption of healthcare operations that has ever occurred. The coronavirus pandemic has fundamentally changed the way caregivers interact with their patients, how non-clinical staff support those caregivers, and how executives manage the business of providing healthcare. Tools that were mere curiosities previously have become the front line of healthcare delivery, and the lifeline that was once relied upon to keep hospitals, health systems, and clinics running is no longer satisfactory or particularly relevant. So let's begin. Tony, as the sole physician on the panel today, and someone who has seen firsthand the disruptive effects of the pandemic on both patient care and operations within the hospital, I'd like to begin with your thoughts on the current situation.
You know, Jim, in my over 35 years as a healthcare provider, I have not seen anything like this that truly, in a matter of days, changed how we provided patient care. We had to flip from an inpatient experience to looking at technology to allow us to provide care. And I think it came up so quickly. I think that we were very fortunate here at Johns Hopkins All Children's to actually have a service line of telemedicine in place that in the period of 2 to 3 weeks, we converted probably 90% of our organization from an in-face to an electronic way of caring for patients. But it was significant. I have not seen anything like this in my career.
Wow, that's incredible. Doug, your thoughts on that topic?
I think over the years, I've had the opportunity to work in community hospitals and for-profit organizations. And from a physician standpoint and perspective of patients, I think there's a tremendous opportunity right now, the way I look at it. And patients are trying to find the best healthcare still in a time when it's not as easy to find. And their ranking of how they look at healthcare has continued to change during this time frame. So I think there's such a great opportunity out there for organizations to find better ways to communicate with their patients and solve problems. So I look at this as a really good time to do something, not to do nothing.
Great point. Cheryl, your thoughts?
Yeah, no, it's been disruptive across the board. We've been tracking this really closely at Forrester Research, looking at healthcare, but of course across all industries. And it's been really interesting to see the data come back just in the last few months, if not even the last few weeks, around how this has forced company priorities to change. Coming into the beginning of 2020, organizations were focused around growing revenue, better customer patient experience, better products and services. And in the same kind of data survey that we saw post-COVID, that order of priority has actually begun to change. We're still seeing organizations focusing on revenue growth, but cost reduction is also coming up as a top business priority. And if we look at healthcare in the U.S. Particularly, we see that they're not immune from overall tech spend, projected budget cuts. Thankfully, in the kind of the low single digits, according to our data, unlike some other sectors that are facing easily into the mid double digit tech spend reduction.
Jeff, your input?
Yeah, I think it's fascinating, Dr. Napolitano, to hear your sort of frontline story of how Johns Hopkins pivoted from in-person brick and mortar care to virtual care, sort of just over the perspective of 2 weeks. And we see that story play out across the country and really across the globe in our data. But it's just so nice to connect the dots to an actual anecdotal experience of what you watched and how you pivoted to delivering that care. But we follow digital health adoption very closely. And so we have a data set from December to February of 2019 to 2020, looking at some of those very technologies and the prevalence that they were being adopted across the country, from symptom checkers and self-triage tools and virtual visit capabilities and remote patient monitoring programs, and really the prevalence of adoption of those different kinds of technologies. And then we have a second data set mere weeks later, months later, in the April-May timeframe, and the lift of adoption between those two surveys is truly hockey stick growth. And when we talk to organizations about what that experience was like for doctors and for patients moving from the one to the other, it's rife with problems. It was a transition that was made in it was 2 years worth of digital transformation in 2 months. It was a transition that was made out of necessity, but will be continually and perpetually optimizing that brand new tech stack for months to come.
You know, I think it's important to note here that there's a lot of organizations out there, number one, that maybe didn't have a telemedicine opportunity available to them and really struggled with attempting to implement something brand new to be able to care for patients. I've also seen, in my career as a CIO, I've seen the rapid adoption of new technologies actually cause problems of their own, right? And actually get between a physician and a patient rather than helping to foster that communication. Tony, have you seen that type of a situation where it's been difficult for patients and physicians to adopt that new model of communication?
I think it's very interesting. Definitely the younger generation of providers are more into the video than we are. But I think that you had identified that it's not just the equipment, but it's the availability of the type of equipment that your patients have. And then all of a sudden we start talking about bandwidth. And we start talking about the connectivity and realizing that the very patients that need you may have poor devices that don't work very well with the
Or no device, right?
Right, no devices, or they don't have an internet system that can support it. So I think where we've seen a bit of a disconnect is that technology works for some and doesn't necessarily work for those patients that really need it the most.
Great point. I've been dealing with a number of community clinics right now that are not only struggling with caring for patients in a primary care environment, but also struggling to manage things like health information management activity or referral management, simply because they can't get staff to come into the office to do those things. So it's the idea of the magnifying glass and exposing the cracks as we frame it here is beyond just, and I don't want to limit the idea of a physician-patient interaction, but there's just a slew of other activity that is required in the healthcare space that is really struggling to be performed effectively, simply because we can't get staff into the building to do anything. So I do think this may be a level of push to implementing new technologies, but those technologies come with their own set of thorns, right? That's the issue. So Jeff, in your opinion, what can we do, or what can our attendees do to make that adoption of new technologies, or use those new technologies to augment maybe staff limitations that they have? What's the easiest way for them to go about doing?
Sure, it's an important question. It's something that I think everyone's trying to answer right now, and it's a very much learning together, learning as we move forward. I think most important is to understand what the problems have been, understand more broadly where we're collectively trying to solve, what issues we're trying to solve. And so I guess I would start there. When we look at the tech stack that and the way that it's changed since the beginning of COVID-19, we're seeing advancements in patient-facing solutions like Dr. Napolitano called out, symptom checkers, increasingly sophisticated patient portals. We're working to integrate with new care settings like drive-through testing centers and pop-up care delivery environments, and the virtual care and remote patient monitoring capabilities that are coming to market collectively are creating an incredibly fractured continuum of care. And we've always, as an industry, had an issue with interoperability, but the rate and pace at which new care settings and new technologies are being deployed are really accelerating that problem rather than solving that problem. So I think the first thing that I would say that we need to be cognizant of as we look at new technologies is consider your interoperability strategy as you're looking at both patient-facing technologies, provider-facing technologies, or Jim, to your point, solutions for back office staff that are working at home, trying to manage referrals management solutions, trying to ensure that the revenue cycle is still processing claims, making sure that we are able to create a data flow that's going to support the hospital or the health system holistically, and not just singularly moving forward with the individual pieces of technology and functionality.
And let's not forget supply chain, right? We saw how bad the supply chain was initially when the outbreak happened. Doug, since you and I have been in the past responsible for implementing technologies that physicians have used, what's your thought around the best way to ease that adoption of new technologies? And I'd also like you to comment on the situations in more rural communities where, as Tony mentioned, you have patient populations that may not have access to broadband internet. They may not have devices for that. Tony and I chatted a little bit last week about the idea of setting up care centers in a library area or in a community pharmacy location where people can come in and utilize bandwidth that might exist in a small area within a community and interact with their physicians in that way. What are your thoughts around that?
Well, first, what I'll say is, when I go down to this discussion, someone once told me, this person was a fundraiser for a not-for-profit organization, said, if you don't ask, you don't get. All right. The healthcare industry has always been excellent at responding to reimbursement issues or meaningful use and those type of things. But the problem is they haven't really put the carrot out in a way that people can consume it. When we did meaningful use many years ago, it was, here's some money if you do this. That was the general discussion. And if you had given physicians, well, here's what a data set looks like when you have all this data that you can actually look at your patient population and make some decisions differently. If you had showed them that, well, at least 60% of them probably would have jumped on board. Okay, there's still going to be a percentage that wouldn't have. So I look at it as that you have to put some things out there because we have really creative people in healthcare. In Nashville, there was a person that when the first COVID virus hit the area, I saw someone doing prenatal visits in a drive-through parking lot, and the husband actually got to go with his wife. Okay, and so we in healthcare understand what's most important. Now, the technology that solved that was probably a printout of some paper that helped facilitate it, but that's not good enough. And the thing about it is, I think if I were to say, if I could spend 10 minutes in a car with the husband and wife, get it done and move through and get my day on and go to lunch, would I want to do that rather than spending 45 minutes, of which I'm pacing through a physician practice. Well, I think we're coming up with new ways to deliver healthcare that are much more innovative, much more accepted by our patients. But our technologies, we buy them off the shelf sometimes. The
Yeah.
technologies come off the shelf, and when we try to say, okay, how do I do this? So it's more that you need more than just an off-the-shelf scheduling system. You need a scheduling system with a workflow engine to
Yeah.
help you do things that are different. Because even though we have a lot of things that are exactly the same in our organizations, there are things that make Johns Hopkins Johns Hopkins. It's a culture of an organization,
Mhm.
and everyone still needs to have the pride in what they do. But the technology, you just can't buy it off the shelf. You have to find some ways to adapt it to your organization. So, and I think if you do that, people will go, this is what we've always needed.
You know,
Okay, and I think you've got to put it out that way. You can't just say, oh, we're installing a new referral management system, and we will do it the way the system works. And like I said, if you don't ask, you don't get. And I think that
Mhm.
technology vendors today are going to have to give you what you need to solve the problems of your organization.
Yeah.
And that includes the cost, that includes the workflow, that
That's a great
includes the
point.
delivery and timing. And if you do that, I think your patients are going to respond favorably, and I think your market share is going to do the same.
Mhm. So, you know, that's a great point. I feel that the technological solutions that have worked the best in this situation have been those that have a bit more adaptive capability to them rather than a hard and fast workflow environment that is, let's call it etched in stone, that doesn't have that inherent adaptability to it. Cheryl, as the one individual here that is not entirely healthcare focused, you have a much more a broader industry perspective around technology, but also the idea of workflow and so on and so forth. So maybe I'll put you on the spot here and say,
Sure.
what industries do you feel are particularly good at using adaptive technologies that that healthcare might potentially benefit from?
Yeah, I wouldn't necessarily say that there's one industry that really jumps out, but I would say it's companies that have made investments in some of the more modern architectures. We used the term interoperability earlier, and my colleague Jeff mentioned data flow earlier. I think these are some of the really key things is, looking for platforms, that can be adaptive, understanding that there's, quite a range in terms of user requirements, whether those are external ones, patients and consultants that we bring in, or the employees that we need to serve a meaningful mobile or web-friendly experience internally. Um, I think that a lot of the interoperability challenges have been that, we're seeing companies have investments still in so many manual or paper-based processes. And those often are the ones that are going to break first, especially when there's limited access to the facilities or offices where, this information is often stored or protected. And I think we're also seeing companies that have not really kept, a modern infrastructure are getting stuck with these older systems that might be very kind of locked in or proprietary, and it makes it so difficult to integrate with some of these newer, perhaps cloud or web systems that may have a great user experience, but don't interoperate well with some of our other key enterprise applications. So, I think it's less about a vertical that's more successful than the other, but it's more about organizations that have already taken those first couple of steps down the path of a more focus on digital business, more digital transformation, and putting customers, patients, those key stakeholders at the focal point in terms of the applications and the priorities. Like, where do they spend that money? Where do they focus? This has raised not only cracks in healthcare services in so many regions, but also just overall business continuity for so many sectors. And I think this is going to be a wake-up call across the board for organizations that have lagged in terms of getting rid of, paper manual-based workflows and getting rid of, those closed older architectures that make it really difficult to move forward from a digital transformation perspective.
That's a great point. So, in the healthcare space, we've tended to rely on interoperability to be delivered by our HL7 interfacing. And that's always been a bit of a discussion that's sort of stuck in my craw, to be honest. The idea of setting up HL7 interfaces between various systems, yes, it's a standard, it's well understood across the healthcare industry, but it's slow to implement, and for community hospitals and health centers and so on and so forth, it's very expensive for them to implement those. In many cases, they're relying on the vendor to build an HL7 interface for communication. I think the idea of newer technologies, the idea of leveraging application programming interfaces, APIs, the idea of leveraging things like web service communication, but that requires, you're right, the newer technology systems, the newer platforms that have those capabilities, and where those capabilities are largely adaptive and easier to implement and get that movement going back and forth. I know we sort of talk about paper processes being easy to break, but I might say that in a disruptive situation, you fall down to the lowest common denominator, and very often that's a paper record. Tony, would you agree with that?
No, I absolutely agree. And I think that as you look ahead to the future, it really is about how systems work together to actually facilitate communication. Now, we're very fortunate here in St. Petersburg as Johns Hopkins Old Children's. We're systematically tied to Johns Hopkins Baltimore, and they have a very, very robust program right now for telehealth. And their robustness, and as they look ahead to the future, they're learning from the here and now, and they're seeing the future and understanding where telehealth, digital health needs to go. But I really do feel that we need to make sure that whatever products we have, we're communicating with our physician providers in the community who are having to deal with the day-to-day operations and are looking to us for support. But we also have to have a better way of how we, as a specialty organization, provide specialty care for those healthcare organizations that may not have access to it. So I really think that as we look at digital health, and I really believe that Hopkins is really trying to solve this. How do we help the patient? How do we help our providers and other healthcare organizations look into the future and don't have those resources, but can again link with us to get some of those resources? It is all about communication.
It's important that Johns Hopkins and these larger, call them tertiary facilities, start to communicate with their communities and maybe even their non-affiliated locations, physicians, healthcare clinics in the community, so on and so forth, about where they may be headed technologically, so that maybe you can have an organization that doesn't have the resources that a Johns Hopkins has, that maybe help them to get on the bus, so to speak, and follow along, right? Because not only do they not have the financial resources in many cases, but they don't have the human resources or the creative juices don't flow quite as well in these smaller organizations as they might in a Johns Hopkins or Doug in an HCA, for instance. That idea of kind of reaching out that helping hand to help these other organizations move forward probably makes a lot more sense now, now that we've had this huge disruption, than it did previously. The idea that you have to reach out and help other people move forward. Thoughts? I'll open that up to the group. What are your thoughts there?
I think we can't wait for another pandemic before we figure it out. And I really think that I feel at times that we missed the boat a little bit here. And I think going forward, we really need to think outside the box. And I think leaders like Johns Hopkins, they really need to be there. They really need to be looking at what resources, and it's not just for those hospitals that are affiliated, it's for everybody. How do we improve? How do we make it better for the patient? And I think we have that responsibility. It's all about how to make patient care better, and particularly for those who can't afford it. We need to be able to reach out to our rural communities, to those people who can't afford it and don't have the technology.
So as a former hospital CIO, my goal was always to have a tool set that I could apply to different circumstances. And that tool set needed to be flexible, needed to be adaptive, so on and so forth. And Doug, you mentioned meaningful use, right? I'll be honestly and say that my opinion of the meaningful use criteria was extremely disjointed and left folks with a feeling that the electronic medical record system was going to be the be-all end-all, the panacea to cure all ills. And the reality was, number one, it probably created some problems that didn't exist before. Tony, I see you kind of chuckling. I can imagine you guys were impacted more than most, but the idea that technology should be more easy to adopt overall, to have that adaptive capability so that it's not one workflow for everyone who adopts that particular software solution, but also has that ability for the creative individual to use those things in different ways that can be leveraged as a tool set rather than as a hard and fast delivered product, let's say. Cheryl, your thoughts on the idea of the tool set version of a software being valuable in almost any organization, I would think, correct?
Yeah, and we're certainly seeing that as technologies modernize and the architectures behind them modernize, we're seeing, the tool sets being designed for a much broader range of users. So you might be a subject matter expert in your particular department. You're not a developer though, but you know enough about how you do business where you might want just a simple templating or design tool so you can get that new workflow moving really quickly, especially in an era like now where things might change on a daily, if not weekly basis in terms of, health and safety recommendations and, appropriate practices. So being able to be nimble, not having to rely on expensive developers, but, the employees, the resources you have in-house to help tune and tailor the forms, the templates, the tasks, the reminders, so that you can keep work moving, but also stay flexible. I mean, that's really where we're seeing some of the innovation happening right now.
Now, I've never been a proponent of moving a clinical workflow outside of the electronic medical record. I think that's important that the electronic medical record support clinical workflows effectively, but I think we all understand, especially now, that there are a lot of workflows that a hospital, health system, clinics rely upon that don't really have a lot to do with clinical interactions with patients. So I think the business systems in healthcare have probably been as exposed to the COVID-19 impact as have the clinical systems. So many of the clinical staff are still in the hospitals, they're in the clinics, they're caring for patients as well as they can. But the back office staff, those people that make the orders happen and refill supplies and so on and so forth, many of them are struggling to work from home in environments that and utilize software that just aren't capable of being dealt with from a vast array of remote locations that have different bandwidth problems and so on and so forth. So the idea of an automated workflow that is accessible externally from the brick and mortar environment, I think is extremely important for those back office providers. But even beyond the back office providers, those supply people, the finance people, IT, that type of thing. I think it's important for the things that have to take place, the health information management activities that have to occur, the referral processes that need to occur from a hospital emergency room to a primary care to a specialist, so on and so forth. Those types of workflows, when you're now drastically disconnected from the brick and mortar organization that you're used to, I think have really been, I've really had the magnifying glass put over them to expose how poorly they have performed in this environment. Jeff, I'd like to hear your thoughts on that.
I would completely agree. Within the clinical care setting and outside of the clinical care setting. So to your earliest point, the doctor-patient experience has pivoted, has moved to a experience that requires bandwidth and patient devices, provider devices. When we look at our data, we see that telecommunications equipment, mobility equipment, these are some of the highest investment areas that we're seeing in response to COVID-19, far outpacing some of the areas that we had more traditionally seen technology innovation. So there's been a clear need identified in the underlying infrastructure layer to improve network bandwidth, to make sure that we have the foundation in place to make this pivot to digital. I think that, so when we look at our sort of where we're going and what's coming, I think that you're going to see the same. We talked about the meaningful use era and the earliest days that technology hasn't always been a positive experience for clinicians or for the doctor-patient relationship. It took, I think for 10 years now, we've been iteratively optimizing service line level workflows to make sure that a pediatric cardiologist is looking at a pediatric cardiologist documentation template and order sets and summary panel for that patient. And that just took time. Well, over the last 3 months, similar to meaningful use, we have shifted from a largely in-person industry to one that is wholly embracing digital care delivery. And I think over the next 10 years, you're going to see the same kinds of iterative optimization and clinical optimization of these tools. And when we look at our data, we see an appetite for sustained use of these technologies. Patients tell us that they feel like the care that they're getting is relatively equivalent to that they were getting in person. Not doctors, but back office staff and sort of end-to-end staff tell us that they anticipate their healthcare systems will continue to maintain a remote workforce at a much higher level that was there before the pandemic. So we have workers that have gone home that probably aren't coming back. We have customers or patients that are visiting us at home that probably aren't coming back into the workplace. And I think that we have that same sort of 10-year stretch of optimization and agile-based perpetual improvement to really dig this new virtual digital front door paradigm in and settle it in the way that we did post meaningful use.
That's great. I have 2 points to comment on that. Number one is the idea of infrastructure and the bandwidth required for infrastructure. I think prior to this, talk about hospitals' VPN connectivity for remote workers might have been sized to support, I don't know, perhaps 8% of the workforce of the organization, largely meant to deal with people who were traveling or folks accessing systems in the evening. And now we've got what was 8% of the staff attempting to use that infrastructure, and now it could be 20, 30, 40% of staff attempting to use that infrastructure where the bandwidth is just not prepared to manage that. So I think there's a level of very, very basic infrastructure that needs to be addressed to support this larger remote workforce than we had prior to the COVID-19 outbreak. But Tony, to a point that you made earlier around the idea of the systems working together and sharing information more effectively, you know, one of the earliest exposures I had as a CIO to that was back prior to the meaningful use environment, where we had one system that was the electronic medical record system for the emergency department, but a separate EMR system for the inpatients. And the two didn't talk to one another. And in some cases, they were even purchased from the same organization, the same vendor, that didn't talk to one another, unless you specifically made huge efforts to make that communication happen. What I saw in those cases, and I think we could probably see it to some extent now with telehealth versus the inpatient records or even outpatient records, was that a patient or their family would listen to questions being asked in the emergency department of a patient, things about, you know, smoking cessation, you know, what's your, you know, what medications are you taking, so on and so forth. And then if that patient got admitted to an inpatient floor, those same questions would be asked, because that information didn't transition from the emergency department to the inpatient record. And you could see either the patient or the patient's family begin to get extremely uncomfortable with that, saying things to themselves, well, they just asked us those questions. And I'm wondering if you're seeing those same type of intercommunication frailties existing now with telehealth to the larger patient record that may need to be accessed by other caregivers or specialists after that telehealth activity has occurred for a particular patient. Are you seeing those same types of issues?
For us, right now, we're in an in-between and moving from one EMR to the other. So at the current time, our telehealth system is independent of the EMR. Mm-hmm. And I really am looking forward that we're going to be moving to one where it's embedded. And I think the future, it's better that everything be there, because the consents that you need, the information that you need to process, not only the telehealth, but the patient feels more comfortable that you see them. And I am amazed right now the comfort that our patients have here at Johns Hopkins Old Children's. They're very comfortable on the video, the telehealth, digital health. And so we are hearing it from them that this is where they want to be. They're very comfortable. Wonderful. We as an organization are looking forward to the point when we are integrated. I think the more integrated the workflow, and I think, Jim, you stressed that, it's all about workflow for the providers. The more the workflow is identified and moves easier, it's better patient care, but it also makes the providers and the physicians who are dealing with the patient, it makes their care feel more where it needs to be. And it even directs care as we look to the future. Best practice comes out, and also with best practice should be a decrease in cost and better outcomes.
Great point. Back in the meaningful use days, I saw systems that maybe weren't the best designs in the world being implemented, and really caused problems for the physicians, because in the meaningful use world, it was all about the collection of data and information about the patient, but it wasn't really about representing that information in a cognitively easily consumable way once that information had been consumed. And I saw, physicians that went from the paper record, where they would easily be able to flip between lab results and pharmacy and so on and so forth, and be able to make a clinical decision more effectively, because they could just put placeholders in and flip between sections of the chart they wanted to use. And then we put electronic medical records in front of them, and in most cases, that information that they wanted to reference quickly back and forth was separated by 20 or 30 pages of electronic records they had to page through. So I saw what at the time I felt was cognitive overload for these physicians to try to make medical decisions using a system that wasn't designed to clearly represent that information. Now, we're what, 10 years past meaningful use activity, so let's hope that those systems have been tweaked over time to be more effective. But I would suggest probably that there are some organizations out there that still struggle with communicating the consumed information effectively to physicians. Am I not right? I'm sure you talk to physicians that are not Johns Hopkins that are dealing with those same issues even today.
I think it's, and most of the literature you read right now is the taxing nature of the EMR on the physician workflow. And I think that, yes, we're very, very fortunate here at Johns Hopkins that we're moving to a system that will work with us. And I think that that's what we're looking for. And as I look at technology, I think that to provide better care, workflow and how it helps us do better care, technology has to come in line with that. I think that you're right. It's 10 years of where we are, but I think there's a better world out there.
Yeah. Well, let's hope that I think Doug and I, Cheryl and Jeff are of the group that are responsible for making that better world happen. And hopefully some of what we get through today allows us to take some things back and make that happen. So Cheryl, along those lines, the idea that the question, what are vendors doing today to better support their customers, and I'll say, in the healthcare specific world, but in the broader case, how are vendors bringing costs down, but at the same time providing levels of again, the flexibility and adaptability that we think is all extremely important in the healthcare environment?
Sure. There's a few areas where I'm seeing kind of the vendor community step up, especially right now. One is, the ability to help customers transition to more cloud-based packaged applications and easy to tailor platforms so they can move a lot of those key processes and applications to an online or again, move away from some of the older architectures and away from paper-based processes. The other thing that we're seeing is, the whole shift to cloud really helping to move some of those more expensive applications, things that maybe were on the horizon for decommissioning, over the next several years. We're seeing a lot of those roadmaps being fast-tracked, more investment moving into the cloud-based applications just because of the ease of use and the better support for so many of those employees who have had to move into remote locations or home office locations. This whole rise of adoption around collaboration platforms especially has been really stunning. I mean, even pre-COVID, we were seeing that about 60% of organizations across industries were looking to expand or implement new collaboration platforms. And that's just exploded, in the last couple of quarters, especially just because it's become such a critical infrastructure component. So whether it's video, whether it's, the secure sharing of data and files, that's really become one of those essential investments to help get through the pandemic and, the phased response to reopening that we're likely to see over the next, several months as well.
So Doug, it's taken us, 45 minutes to have the term cloud injected into this conversation. It's but might be a little bit stunning to some of us that it took us that long to get there. But my thought is that cloud-based solutions, number one, they reduce the amount of infrastructure an organization has to spend money on to be able to manage those systems that maybe are in-house today. There's a limit to the number of servers we need to buy and the staff we need to manage those servers. But on top of that, the cloud-based applications remove the difficulty of a remote workforce, right? Because a cloud application inherently can be accessed ideally from, quote, anywhere. And that does seem to be some direction that the healthcare world needs to consider pursuing, that other industries that Cheryl's probably been exposed to have already sort of adopted in that realm. So what are your thoughts on, how we leverage cloud to make this a little bit more effective for not only the Johns Hopkins of the world, but all the way down to a community health center trying to care for underprivileged patients?
Right. In the last 10 years, a lot of the healthcare technology development has been around regulatory change. So much around that area. Over that time, there have been lots of people trying to move their systems to the cloud. And what they've been trying to do is just move their systems to the cloud, and it's just a data center in the cloud. Cloud computing that does not let you take advantage of the efficiencies of cloud computing. So I'd say there's lots of great technologies out there that work on the cloud that utilize the advancements that come from cloud technology. And those are the ones you need to be looking at. They integrate your organization. One of the things that we talk about sometimes is, when do you want to start? Okay. A lot of organizations, you'll say, okay, when do we order the equipment? When is it going to be in the data center? When is this going to happen? In large organizations, as you probably know, it probably takes 9 months to build a team to put the data center together to get started on a project. And I would say we don't have time for that anymore in this organization. If you're going to make changes, the organizations that can make the best changes that fit the culture, that also fit patient and physician needs, are going to be the ones that are going to be successful. And that's exactly what the cloud does. If you look at what Amazon does to attract us all to purchase things on the cloud, okay, there's a lot of reasons they can change faster than other organizations. And I think that most of the time, I don't really talk to organizations about the cloud. I talk to them about what they want to do, what they want to solve for. But if there's a cloud option that can solve for what they want to do, they should be running to it, because, as Cheryl said, cost is an issue, and the cloud will bring you scale. No matter if you're a small organization or a large one, it'll give you scale that matches the services of any other organization. And that's what you should be taking advantage of, the scale of solving problems better.
You mentioned one thing that I found very interesting is the idea of the cloud is not the same to everyone, or even the vendors promoting cloud solutions. Some are, as you mentioned, not a whole lot more than a data center in the cloud, right? And that's what we used to call the old ASP model, right? It was a hosted environment stuck off in a data center in, who knows, South Dakota somewhere. But it was really the same systems that you ran on premise that you just run in an ASP model. And I think there are some situations where there are vendors promoting what they term to be a cloud solution, which is really not a whole lot more than an ASP model hosted solution that happens to be in an Amazon data center somewhere. So the point that you make, which is there's a big difference between how people implement the cloud and whether you're really getting a leveraged value from having a cloud-based system versus just having the terminology cloud that happens today to be the hot button for so many things. Jeff, your thoughts on the idea of the cloud and how various vendors promote a cloud solution versus some that maybe leverage effectively a true cloud-based environment?
Yeah, sure. So when we talk to our healthcare user organizations, the hospitals and the payers and even the life sciences organizations that are the buyers in these conversations, they lean on their vendors very heavily to bring their applications to the cloud. It is only very recently that we've started to see partnerships directly between public cloud vendors and enterprise healthcare organizations. And Dr. Napolitano, I'm sure that you're aware, just about a month ago, Johns Hopkins announced its relationship with Azure, where they would be working directly with Azure to accelerate precision medicine and essentially moving both their data and compute resources to Azure Cloud to start moving forward on some of the genomics research that they're doing. I think that for about the last 18 months, we've watched a steady increase in the public cloud enterprise healthcare partnerships. You saw this with Sanofi and Novartis on the life sciences side. We saw this with Providence St. Joe's, Mayo, of course, Johns Hopkins on the provider side, and even the ISVs with Cerner's decision with AWS and Meditech's decision with GCP. So I think that you're going to continue to see whole hog adoption of some of these technologies, but it's early days for, and really just the most innovative, most prolific health systems that are moving forward at this very early stage of directly engaging with public cloud vendors. But I think that's the future. We've talked pretty extensively today about how interoperability has created data silos across this increasingly fractured continuum of care, that we have public cloud provided symptom checkers that are being bolted onto the top of patient portals but not sharing data, and then patient portals and EHRs. And Dr. Napolitano, and I'm sorry to hear that you're using a non-integrated virtual care solution and that's causing problems, but I assure you that you are not alone. That is the #1 problem that health systems are coming to us about right now in response to COVID-19, is a lack of integration between virtual visit technologies and their core EHRs. So it is very much a commonality that we're seeing across the board. And so I think you'll continue to see, when we look at if you double click into these partnerships and you really look at the details of what they're aiming for, it's creating a 360-degree view of the patient that can benefit all, and really engineer a solution to the fact that there are compelling point solutions, and they don't need to share data point to point to point. They are engineering a centralized 360-degree view of the patient that can federate all of those products.
Great point. The interesting thing is the cloud environments, #1, have a scalability that is unheard of in the on-premise world. So with organizations, healthcare organizations that are in acquisition mode and bringing other physician practices on board, or frankly, acquiring another hospital and attempting to put the systems together from two dissimilar organizations into one. When you think about an on-premise solution, you're really, if you're taking an organization that is not on the same EMR platform that you are, and you're acquiring them and trying to bring them into your organization, really in the previous world, the only option you had was to stand up an entirely new version of the product that you had, which is literally, in cases, hundreds of servers, massive amounts of networking equipment to bring that new acquisition into your platform. With the proper cloud environment, it's a 2-day issue to say we're going to need X number more resources from Amazon Web Services or Microsoft Azure or whomever your cloud provider is. It's a very easy, scalable environment to be able to manage that much more effectively than you could when you were entirely on premise. Now, I'll say this. 3-4 years ago, when you mentioned cloud to a hospital, the first thing they did was back away and ask you to leave the room. They just were not interested in implementing anything in the cloud 3 or 4 years ago. That has completely changed now. with the security that exists in the cloud. And in many cases, with the right cloud-based provider, I would say the security is better in the cloud in many cases than it is in a client's own data center environment. And I think we're seeing some of this with the retail penetrations that are happening, where people are losing credit card information and so on and so forth so often. So we're coming down to time now. We have about 3 minutes left. I'll ask folks to just do a short closing comment if you have something. Cheryl, something for closing for everyone?
Sure. No, I think this has been a really informative conversation. And, if we think about, the cracks in the healthcare system that have been exposed here, I mean, that can be translated to both patient-facing, processes and activities, but also, so many of those back office activities as well. And that also crosses into other sectors. So I think main takeaway I'd like to leave everyone with is, think about that business continuity, that patient first, customer first point of view, and where can you use technology to keep these systems moving in a positive direction.
Great. Jeff, your thoughts?
Sure. Yeah, thanks, Jim. I think the most important takeaway from my perspective is that we talked a lot today about the lessons that we learned from the meaningful use era, and the fact that we are right at the beginning of a digital transformation journey wherein we are bringing digital care wholly into the continuum of care. And when we surveyed, even just this past December, health systems in the United States to ask them about how they're measuring physician experience, physician dissatisfaction with technology, and the doctor-patient relationship, more than 40% told us they had no strategy at all for measuring and managing physician dissatisfaction. And so I would just reiterate that as we move forward at this blistering pace implementing technology, we need to put the doctor-patient relationship in the center, and we can't do that if we're not measuring.
Great. Tony, you got about a minute. Your thoughts?
Very, very exciting to hear you all looking at it from the patient care and the provider side. I think going forward, we have to enter an era where this is what the demands of our patients are going to be, and we as a healthcare system really need to figure out how do we do a better job with it.
Great. Thanks so much. Well, that's all the time we have today, folks. We appreciate you joining GRM and Forrester for this panel discussion on COVID-19's disruption of our healthcare system. And we hope you not only enjoy the varying viewpoints, but also receive some insights you can put to use in your own organizations. Thanks, and have a great day.